If you take a drug that works, you get better. If you don't take a drug that works, you don't get better.
We could save upwards of 132,000 lives a year just by providing equal care. No new drugs, no new innovative therapies, just giving the same care regardless of that person's ethnicity or race.
That's right. By the way, that's 132,000 out of the 600,000 or so who die every year from cancer in the United States. And the interesting thing is 70,000 of the 132,000 are people who call themselves white. You see, the largest group of people who suffer from health disparities are white. They're generally poor white. They're more commonly from the South and red states than any place else.
This is Genetics for Healthcare, a podcast for patients.
This is Genetics for Healthcare, podcast dedicated to patients and their caregivers to advocate for a precision medicine approach to their care, which includes disease screening, survivorship, prevention, and of course, treatment. You can find us at geneticsforhealthcare.com. From there, you can go to any of our social media platforms and follow us to get updates on new episodes like this one. Today is an honor to have this conversation with one of the experts in the space on cancer disparities and just cancer care that I have admired, that people that I admire and follow have pointed to as their role models in this space. Dr. Otis Brawley, medical oncologist at the Johns Hopkins Kimmel Cancer Center, and one of the lead authors on a paper that we're going to be getting into today that's sponsored by the American Cancer Society. Dr. Brawley, thank you so much for taking time to talk with us here at Genetics for Healthcare.
Well, thank you for having me.
So I've got to ask you your backstory. I love to understand what inspired you to a career in medicine and what along that way particularly steered you to oncology.
Well, growing up in Detroit, I was always interested in science. I was also always interested in politics. I was steered toward the Jesuit high school in Detroit, and that really got me into thinking a lot. And the Jesuits are heavily about questioning. And I ultimately went to the University of Chicago and majored in chemistry and was pushed there toward going into medicine. I found scientific research or medical research very interesting. I found some of the policy issues around medical research and especially cancer very interesting. And I was pushed toward training in medical oncology because back in the 1970s and 80s, and even today, there is a lot of policy issues regarding cancer. And I've had a fun time. I was very fortunate that I got picked up by David Satcher when he was Surgeon General, and I was asked to do a series of studies. David Satcher was the person who put the words health and disparity together. He was very interested in the fact that some people don't do as well as others, and he used the word health disparity to make sure that everybody understood exactly what we were talking about.
Well, on that note, the reason I came in and came aware of your influence and what you do, the work you do, is Karen Wingfield. See, Dr. Brawley, I am getting old and forgetting names, but if I forget it, it will come back when I need it. Dr. Karen Wingfield did ask me, and this is 10 years ago, do you know about the work of Otis Brawley? And I did not. And so, present day, the American Cancer Society started in 2021, publishing a biennial report every 2 years on the status of cancer disparities in the United States, and it was published in December of 2025. It was called the American Cancer Society's Report on the Status of Cancer Disparities in the United States 2025. We'll have the link to that paper, or at least the summary, on our episode landing page. So we've been aware, as you've mentioned, that there are treatment disparities in cancer care and the myriad of contributing factors. I think the first question I've got is why? What was the genesis of the American Cancer Society sponsoring this study, and why did it take to 2021 to do it?
Well, I was the chief medical officer of the American Cancer Society from 2007 until 2018. And so, trust me that the American Cancer Society has done a great deal of work having to do with disparities in health. Uh, Probably the most important thing we ever did was campaign hard for the Affordable Care Act, which is an effort to get people adequate, high quality care. Over the years, we have published about the geographic differences in outcomes. The current report that you see is a title change and putting everything in one place. And that was something that was started by the folks at the American Cancer Society in 2021. The then CEO wanted one paper every 2 years.
In the paper, you track cancer occurrences and outcomes by sex, race, ethnicity, if you will, socioeconomic status, even geographic location, whether patients are treating in urban areas or rural areas. Again, all um, contributing factors, and there are others that contribute to cancer disparities that you allude to in the paper. And along with these, um, the screening, the social determinants of health, and other health related social needs, I can't help but look back to the history of civil planning in the United States and the role that segregation, redlining, that has created pockets of poverty. In fact, I think I read this in the paper, or it may be in a commentary about the paper, that you said that poverty itself is a carcinogen. It's not just DNA, it's not just access.
Uh, you're absolutely correct. Let me attribute that statement to Sam Broder, who was director of the National Cancer Institute in the early 1990s. He's the first person to say poverty is a carcinogen. And it is absolutely correct. When you look at uh, poor people, they have higher incidences and higher mortality rates for cancer. You can look at it through family income. You can look at it through area where people live. Poor areas of the country will have higher death rates versus wealthier areas of the country. You can look at it by education. One of my favorite examples is if you look at college educated women in the United States, the cancer death rate is for every 100,000, 60 die each year from cancer. If you look at high school educated women in the United States, for every 100,000 women, 120 die every year. The risk of a high school educated woman dying from cancer is twice that of a college educated woman. And by the way, education trumps race.
So I think that's a good point. And one study that mentioned, if you look across the board at ethnicity or race in the incidence of cancer diagnosis versus the outcomes, if we're just looking at a disease like breast cancer, black women are white women have higher incidence of breast cancer diagnosis, but Black women die at higher rates.
Mm-hmm.
And even when you look at education rate across that demographic, Black women still have unfavorable outcomes. I just spoke to Dr. Alexia Gaffney on the podcast. She's an infectious disease doctor in the New York area. And despite her family history of cancer, father, prostate cancer, uncles, other people in the family. She had a high concern that she would develop breast cancer. You can find that episode 54 here on Genetics for Healthcare. And she advocated for getting um, a preventative mastectomy that would reduce her risk of developing breast cancer. And even though she is in a healthcare system going through the system, and these are her colleagues, and the people in her system said, hey, don't worry, you got the dream team. This is the folks you want to go to. And in advocating for this preventative measure to avoid a breast cancer diagnosis, her doctor said, "Well, that's a little too radical. We don't want to take off, both breasts. You should just do a lumpectomy for a lesion that we found there that we may not know is cancerous, before they did the biopsy and the diagnostic workup." And then she started kind of negotiating with her surgeon to say, well, if I have a genetic variant that will qualify me for this mastectomy. And the surgeon said, well, you don't qualify for that. You don't qualify for genetic testing. And here's the thing, Dr. Brawley, it's not that she didn't have the out-of-pocket cost to do the test herself. I mean, she could have paid for it cash. It's the fact that there's misinformation and experts in the field that patients put their trust in to counsel them on their best options, but they're not properly informed. And here's the catcher. Here's what I wanted to get to. In her experience as a Black woman going through, she said, I had to remember back to when I was going through med school. And at the end of every disease state that we studied, it was, but Black patients performed worse or they died from the disease. And she said that in training, it's almost as if clinicians are let off the hook when they're treating patients of color, specifically Black patients. How do you respond to that in terms of just the experience of her being a doctor, not getting access and
Well, I'm not sure she got bad service. I honestly don't know. I don't know her situation. I cannot speak directly to her situation, but I can tell you that there are, as a breast cancer doc, or a doc who does cancer and a doc who does screening, I can tell you that there's a whole bunch of women out there who are demanding bilateral mastectomies who shouldn't be getting them. Now, there's some who should be getting them as well. And this is how the system gets totally messed up. It's really not a system, quite honestly. To call what we have in healthcare system is an affront to the word system. We have people who want healthcare and want to consume healthcare that, quite honestly, if we're good scientists, they should not. And we have people who are not consuming healthcare that they should be getting. Let me give you an example. The paper that made Otis Brawley was 20 some odd years ago when we said, gee, in metropolitan Atlanta, 7% of Black women who got the message get a mammogram, who then got diagnosed with a localized curable breast cancer, got no treatment in the first year after diagnosis. It was 3% of white women, by the way. Now, we have a bunch of folks who have an idea of what health care they should be getting, be it in prostate cancer screening and treatment, breast cancer screening, treatment, and other things. And it's just wrong. And what it does is when they get that care, sometimes they're harmed because they got that care. Sometimes they consume resources and they make the line longer for the poor folks who actually need those resources. So I'm not, again, I'm not speaking to her situation at all. She may have been in a situation where she should have gotten a bilateral mastectomy. She may not have. I don't know. I've seen both happen.
To close the loop on that, ultimately, she was biopsied. It was found to be breast cancer, a stage 2, I believe it was. I don't know the histology. And after that, she did get genetic testing and was found to have a PALB2 mutation. And, her platform, her message now is obviously to advocate for yourself, go to the proper clinicians who could properly counsel you, because a breast surgeon, even though they all want the best for their patients and are going to try to do their best, he ultimately was not the expert who needed to be counseling her on her risk and the subsequent actions that she
I
could
can
take.
agree. I can agree that what I would love to see everyone do is see actually a genetic counselor. Unfortunately, the number of certified genetic counselors in this country is very small. And every time I send someone to a genetic counselor, the wait is so incredibly long. That's one of the resources that we're short on.
What was found in the paper with respect to the trends, and what's changed since uh, the first iterations of the paper? Are you seeing trends improve in terms of reducing disparities, or are they getting worse with?
Well, we've seen, I like to look at mortality rates when we talk about disparity. You can look at incidence rates. Incidence rates can vary by how thorough a group of people are being screened or assessed, but mortality rates, they're really hard and they're more concrete. Mortality rates have been going down for all the races over the last 30 years in the United States. Black rates are still higher than white rates. White rates, by the way, are higher than rates for Native Americans and Asian Americans. Hispanics are an ethnicity instead of a race, but their rates are also lower. Um, we still have a black white disparity as we have a white disparity with the other groups, but everybody has been going down. I look at disparities amongst the races as a failure of a spectrum of prevention, screening, diagnostics, and treatment. Sometimes we look too much towards screening as the answer to these things, and we don't think about the preventive aspects. For example, uh, right now, we're at a time point where obesity and lack of physical activity, we call it energy imbalance. And it's really consumption of too many calories, not enough exercise to burn them off, and then storing that caloric energy as obesity. Obesity is about to become the leading cause of cancer in the United States. It's about to
Mm.
surpass tobacco. We don't focus enough on getting people to ideal body weight. And this is especially a problem, by the way, in the Black community, where Black women have the highest rates of obesity amongst women of any race in the United States. We need to focus on prevention, that's smoking cessation, diet, exercise, and we need to focus on getting people the appropriate screening. I see so frequently people focus on one disease and ignore everything else. The woman who gets screened for lung cancer, and the radiologist says, well, her lungs are fine, but you do know she has stage 3 breast cancer. It turns out
Mm.
the 60-year-old woman has never had breast cancer screening, ever, but she's getting screened for lung cancer. I don't know if prostate cancer screening saves lives. It might, but I see these free prostate cancer screening programs uh, where the men are lined up to get screened for prostate cancer, and they have cigarettes in their shirt pocket. Nobody's telling them don't smoke. Nobody's checking their blood pressure, both of which are more likely to kill a black man than prostate cancer. Speaking of lining up, we get screening so frequently in ways that don't make sense and are of lower quality. People should be going to a doctor and in a program of screening for all the things they should get. They shouldn't just get prostate cancer from screening from a van somewhere where nobody knows what their PSA was a year ago or in the future. Or when we talk about mammography, I hate mammogram vans. The reason why I
Mhm.
hate mammogram vans is number one, the message from a mammogram van is get a mammogram, not get into a program of high quality regular mammography. And number two, most of the mammogram vans in the United States don't try to find previous mammograms for comparison with today's mammogram. That, by definition, is low quality mammography.
Mhm.
Frequently I'm said, well, 60% of black women are getting mammography. 60% of white women are getting mammography. What's the problem? The problem is poor people, and there are more poor black people than poor whites, uh, tend to get mammography on mammogram vans, which is lower quality. And we frequently don't think about quality.
So, okay, that brings up something. So you're talking about, getting them into a good system where they understand the long-term value of that follow-up. And this could be for any disease, cardiovascular, diabetes, all those things as well. Now, specifically when we're talking about the area of precision medicine and cancer care, the availability of hereditary cancer testing, germline genetic testing, provides an opportunity to identify which patients are at risk, and then, as you mentioned, get them into a program for screening to at least catch this early if you're at a higher risk of developing different diseases. Obviously, there's disturbing trends in colorectal cancer becoming a prevalence of younger, early onset colorectal cancer. But this does provide an opportunity in our lifetime that we can have information that prevents a cancer diagnosis and that can benefit your family for generations to come if you carry a variant that makes you of a higher risk for developing a cancer. What role, and do you allude to this in the paper, does hereditary cancer testing play to curb the trend of
Yeah.
cancer disparities?
Well, about 15% of cancers are hereditary. That's about one out of every eight. There are certain families that have higher risk of cancer. And what in the ideal world, if we had people who knew my family history is such that I have a number of cancers, I should go to a physician who would send them to a genetic counselor, and the genetic counselor would look at their family history and then decide what genetic tests they need to get. That's the ideal. Unfortunately, a, a we have a medical, I hate to call it a system, we have a medical system where it's catch as catch can, and some people will get the appropriate studies and some people will not.
What gaps need to be addressed in this system, as we call it, to really reduce the cancer disparities? Because I mean, there are so many contributing factors. I don't know if you get into determining factors like health and smoking and cessation and all those things, but from the disparity level of those who are affected most, um, unfortunately, the interaction or the engagement sometimes is the mammography van or bus. Sometimes it is a community event where they're trying to get men who don't go to the doctor frequently to do PSAs. What's the gap that needs to be addressed at the hospital level?
Yeah, well, I like to try to back up as much as possible in the prevention. One of the things I love to do is to compare people who live in certain areas versus other areas. For example, in breast cancer, I find it very interesting that there are areas of the country or states where the breast cancer death rate for Black women is three times higher than it is for other states. Okay? And uh, I keep hearing about Black women having more genetic susceptibility to breast cancer, but for some reason, Black women who live in New York and Massachusetts don't have that susceptibility the way Black women in Mississippi and Alabama do.
Mhm.
Okay. And for folks who might not be listening fully, what I'm saying is there are areas of the country where Black women with breast cancer get less than optimal care. Less than optimal care is a euphemism because you might have some young people listening to the podcast. Um, when we talk about uh, prevention, smoking, the fact that we still allow menthol in tobacco. Menthol, by the way, is kind of, you mentioned redlining earlier. Redlining was something that the federal government did that in the 1930s that we're still paying for today. I mean, I can look at redlined areas of the country in the 1930s and tell you that people who live there today have higher cancer death rates. Menthol, the tobacco industry specifically targeted and advertised menthol to Black men more so than anybody else. And to this day, 70% of Black men who smoke cigarettes smoke menthol. It's about 25-30% of whites. Black men overwhelmingly smoke menthol. Menthol is an additive that's put in tobacco that helps to make it be more addictive.
Mm.
Okay? Why is it the federal government can legally bar menthol from being added to tobacco, but the Biden administration chose not to do it, and the Trump administration has chosen not to do it? Why are we selling this addiction to people, this addiction that disproportionately affects Black people? It just don't make sense to me unless you want to kill Black people or make money off of it.
So, okay, so let's dive into that. So, there is a history of medical distrust in the Black and Brown communities. When I grew up, I'm from small town Texas, and it was certainly like I knew about racism from the time that I could hear. I mean, it's just it's part of our community, and these issues have started to be uncovered and illuminated for uh, for the country and just for the world to reckon with a few years ago. I think many are aware of the Tuskegee experiment that ejected Black men.
Many people don't realize what happened at Tuskegee, though.
Let's pause there. Go ahead and talk about that because there's Henrietta Lacks. There's even major institutions like Penn and UVA and Harvard have started to deal with once upon a time the institutional reckonings of this medical racism, practice of medical racism. But if you can tap into that a little more.
Okay. Uh, there are a bunch of stories out there about Tuskegee that are just wrong. I keep hearing that the government gave people syphilis. What they actually did was they watched people who already had syphilis. They watched them over time and compared them to people who didn't have syphilis. They even watched them after we had a treatment for syphilis. And part of the reason that they watched them was there was the belief that syphilis didn't kill Black people. You had to be higher human in order for syphilis to kill people. And part of the study was, is syphilis actually a disease that kills lots of Black people the way it kills lots of white people? And it gets into this Black biology is different from white biology, which is quite honestly garbage. And that was motivated, a number of things over the years have been motivated over the biology of Black people is different from the biology of white people. Many people think we have to accept these disparities in breast cancer, for example, because Black women have a different kind of breast cancer. Oprah's even referred to it as Black breast cancer, which drives me crazy. I go to places like the Walter Reed Military Medical Center, which is a military hospital just outside of Washington. It's in Bethesda. And they published their experience in treating Black and white women, and equal treatment yields very close to equal outcome. Race is not much of a factor in outcome when you give people adequate care. There is still a little bit of a difference, but we use this biological thing to say we just have to accept the fact that more Black women are going to die from breast cancer. When I look at prostate cancer, now prostate cancer is an interesting one because, men who get certain genetics from northwestern sub-Saharan Africa have a higher risk of developing prostate cancer. Men from Eastern Africa and men from Southern Africa have, in some instances, lower prostate cancer rates than white guys from Europe. But we keep saying it's Black men. It's area of geographic origin. Race is not unless you want to start saying men from East Africa and Southern Africa are not Black. We need to start talking about area of geographic origin. All right. Now, once a man has prostate cancer diagnosed, I have data to show stage 2 prostate cancer that's treated appropriately has the same outcome, be the man Black or white. I have lots of data to show that if you're Black and stage 2, you're less likely to get good treatment for your prostate cancer. But I have good data to show equal treatment yields equal outcome.
In the paper, I believe you stated that we could save upwards of 132,000 lives a year just by providing equal care. No new drugs, no new innovative therapies, just giving the same care regardless of that person's ethnicity or
That's right.
race.
By the way, that's 132,000 out of the 600,000 or so who die every year from cancer in the United States. And the interesting thing is 70,000 of the 132,000 are people who call themselves white. You see, the largest group of people who suffer from health disparities are white. They're generally poor white. They're more commonly from the South and red states than any place else. But we could save in breast cancer, the number of Black women who die needlessly every year from breast cancer is a little over 1,000 of the 5,000 Black women who die from breast cancer every year. We're talking about 1 out of every 5 Black women who die from breast cancer. That death could have been averted if we had a system that provided adequate, high quality care.
And I don't want to, I've got to go back a half to a full step because you said this minutes ago, and I didn't want to zoom past that so people listening can understand this. You said obesity is starting to overtake or to come to the levels as a cause for cancer in the United States.
Yeah.
And again, this is not relegated to one race of people, one community of people. That obesity is affecting everyone and is the leading cause of cardiovascular issues, diabetes, and now it's starting to impact the development and the trends of cancer rates.
You're right on target. All the major chronic diseases, diabetes, cardiovascular disease, stroke, and cancer are caused by, for years, the number one cause has been smoking, but smoking has gone down dramatically since the mid 1960s. What has come up since the late 1960s is we call it energy imbalance in my world. It's consumption of too many calories, not enough exercise, and then storing that caloric energy as fat. We can measure it best as obesity. That is the leading cause of cancer in the late 2020s, and it causes diabetes and cardiovascular disease and stroke.
Let me tap into this because we were just talking about, and as you expounded on this, the Tuskegee experiment very, very articulately. I appreciate that. The history of medical distrust in underserved communities. Do you still see a reluctance from Black people to participate in clinical trials? And here's where I'm coming from, Dr. Browley. I'm on record of sounding the alarm. I'm obviously not a doctor, PhD. I am an informed observer of precision medicine, and I am on record of saying that if underserved communities don't understand, if they're not aware or have the confidence and the knowledge to advocate for themselves, to access to tumor profiling or hereditary germline testing, pharmacogenomics, that these disparities could get wider because we're not getting access to these things. Do you still see a reluctance of Black patients to either participate in clinical trials or get testing when recommended, tumors, uh, hereditary cancer testing, and what might contribute to that either way?
I see less of a reluctance than I hear is out there. Uh, what I hear, actually, we've done studies of this, and about three quarters of in cancer, about three quarters of Black people, about three quarters of white people, about three quarters of Hispanic people who are offered to go into a clinical trial say yes, and it's about the same proportions. Now, in order to say yes, you have to have a good relationship with your doctor. There are people who think the system is up against Black people, but my doctor is okay. And if my doctor is okay and the doctor says you want to do this, they will. Now, I encourage people to go into especially the well designed national trials from the, ironically, from the federal government, from the National Cancer Institute, because we've got a lot of studies to show that many people, Black and others, treated for these diseases get less than optimal care. But if you're on a clinical trial, the rules have been written as to how the treatment's supposed to be given. And there's an auditor who comes through to make sure that the treatment was given correctly. So going on to a clinical trial is actually a better way of assuring that you're going to get appropriate therapy. And if you qualify to go on to a clinical trial, it's not just your doctor thinks this is appropriate to you. It's 20 experts in this disease have gotten together and wrote this clinical trial and said people like you are appropriate for this clinical trial. So think of it as you're getting not a second opinion, you're getting an opinion from 20 experts in that particular disease. So I encourage clinical trial participation as a way of improving the quality of one's care.
I want to dive into what you see the future of disparities research to be. And here's why I say that. The FDA, along with ASCO, sponsoring this particular paper that looks into cancer disparities in the United States, the FDA, in an effort to improve clinical trial participation and also to have a more representative um, cohort of people that participate in the trials to see how it affects, different people, they issue a guidance document on eligibility criteria, enrollment practices, and trial designs. And I'm just going to read this from that document. Again, we'll have that link on our episode page at geneticsforhealthcare.com. But it says enrolling patients in a wide range of baseline characteristics may create a study population that more accurately reflects the patients likely to take the drug if it is approved and allow assessment of the impact of those characteristics on the safety and effectiveness of the study drug. And now, the lay interpretation might be we need more people of color in the study, right? We can't have a reference set that is, 100 people that are, white people from Buffalo, New York. But with the current environment that we're in, including the recent Supreme Court ruling that says you cannot, make certain changes to jurisdiction based on race, right? Does that ruling set up a collision course with this recent FDA guidance document advising drug makers to invest?
Yeah, the ruling itself, I don't think so, but there is a movement separate from the ruling that is against anything that's minority, anything that's Black, anything that whole mindset. There's also an anti-science mindset out there truth be told, there are differences in how people metabolize drugs. Race is not the right way to do it. Now, unfortunately, they may use that statement to stop studying how we get better treatments to Black people. Area of geographic origin, again, is the best way to do it. Of course, most people don't know their area of geographic origin, and many of us are a mixture of a number of geographic origins. But studying these differences are important, and studying them carefully are also important. If you have time for just one story of how this blew up, in the development of the drug zidovudine, or AZT, as an anti-AIDS drug in the early 1990s, some very open-minded people made sure that there were a large number of Black people in the trial. And this was a study of almost all gay men. About 25% of the trial was Black, 75% was white. It was AZT versus placebo. We had no treatment for the disease at that time, so it was ethical to use the drug versus a sugar pill to see if the drug was better than the sugar pill. Ultimately, this was a study that was published in one of the leading journals in the country, front page headline, New York Times above the fold. First drug shown to be effective in treating AIDS. Subheading, better in whites than in Blacks. Okay, so so the people who did this study looked at how it worked in Blacks, looked at how it worked in whites, and they found that it was better in whites. But they didn't feel comfortable with that, even especially after that headline. And so they looked further, and they found out that Black men, you had to take the drug 5 times a day. Black men ended up taking a little less than half of all the prescribed drug. White men ended up taking 95% of the prescribed drug. And so the first thought, we have these racial blinds. There's some side effect that Black people have that keeps them from taking the drug. Then they finally got somebody who was smart and actually knew Black people. This is why you need to have Black folks helping to run the trial. And they figured out the Black men in the study were gay men who were still closeted. The white men in the study, they went home to mom so that mom could help take care of them. And it was the nursing care that their mothers gave them that allowed them to take 90 to 95% of the drug. The
This
guys who were
is Genetics
closeted
for
and living
Healthcare, a
alone
podcast for patients.
just couldn't take the drug as adequately. And what they proved was, if you take a drug that works, you get better. If you don't take a drug that works, you don't get better. Now, this was published in a journal as well, but it was never shown above the fold front page New York Times. Now, we haven't prescribed this drug to treat AIDS for 20 years. We've got better drugs now. The study was published 34 years ago. Okay, there are some people in Baltimore, in the hood in Baltimore, who still say, those AIDS drugs, those are for white people. They don't work in Black people.
Mm.
Okay, the end result of that study and the mistake of that study 35 years ago is still with us 20 years after we stopped giving that drug and went on to some stuff that's better. We got to be careful. Got to be careful when we start looking at these Black-white differences.
It just goes to show there's always data behind the data to dig deep, and especially, and not talking about from a consumer standpoint. We're talking about from a provider standpoint, from an expertise standpoint. So I'll let you go on this. This is airing during the ASCO, the American Society of Clinical Oncology meeting, is the largest gathering of cancer care providers in the world, well over 40,000 people. So I'll ask you, I always ask experts for 3 practical tips on how we can become better advocates for patient access to precision medicine, in this case, hereditary cancer testing or other types of genetic or genomic tests that can improve care. But I want you to speak to your colleagues. What are 3 practical tips that we can give them to think about implementing or considering for their program to reduce cancer disparities in their area?
Well, the first is against hubris. There are people who think they know the answer. And going back to the Jesuit Catholic priest who taught me in high school, Father Polakowski used to say, you should always label things what you know, what you don't know, and what you believe. And keep in mind that um, a lot of things that you think you know ultimately turn out to be not true. We need to always be questioning. We need to always be thinking. Second thing is, please do not assume that because you have a dark skinned patient in front of you, they are not going to go on to a clinical trial, because very frequently we don't have blacks on clinical trials because a lot of doctors have been convinced they're going to say no anyway. I'm only going to alienate them by offering them the clinical trial.
That's a big point that I don't think is talked about enough. The doctor saying that the cost or this me even approaching him with clinical trial is kind of a no-no because there's no trust there.
Yeah, that's right. And then the last thing I would ask doctors to do is, if you feel that you cannot provide this patient with the highest of quality care, please tell the patient and please try to help the patient find that optimal care.
Dr. Otis Brawley, medical oncologist at the Johns Hopkins Kimmel Cancer Center and one of the authors for the paper, the American Cancer Society's report on the status of cancer disparities in the United States, published in December 2005. Dr. Brawley, I cannot thank you enough for just lending your insights.
My pleasure. Thank you. Thank you for what you're doing.
It is my mission of my platform to close this gap in patient access to precision medicine and to be a platform to bring light to issues just like this. So thank you for being a great guest on Genetics for Healthcare.